as we enjoy a fun conversation with our guest, Michael, who I'll be introducing here in a minute. Encourage you to, throw questions out, throw them in the chat, or just, jump in. It's okay as we're kind of pivoting from one subject to a next to just jump on in. We would prefer this to be as collaborative and conversational as we can make it. So with that, I know we're just a few minutes over, but I think maybe that would be a good time to just start with welcoming Michael and giving a quick introduction. So Michael and I know each other through, I think, both the HIMSS interoperability group that we were on together for a while, and then also the Carequality Advisory Council. So Michael has 30 years, 30 plus, and I identify with that because I also stopped counting at 30 and just do 30 plus. No one needs to know how much over 30 it is. My gray hair will probably share a little bit of that. But 30 years working in healthcare technology, both from the vendor, the government, and the provider perspective, focusing on new technology implementations. And not a surprise since he's here today with a specialty in data interoperability, systems integration, and digital technology innovation, and has worked with data standards as varied as our X12 EDI data standards, and then of course all the HL7, the V2, V3, CCDAs, APIs, FHIR, and as I can attest to, he's very involved in overall technology policy and governance. And just to name a few, I mentioned the Carequality Advisory Council. He is the co-chair. And how many years have you been co-chair now, Michael? It's been at least
4 or 5. We regularly ask for new volunteers, but I'm you know how they have that line where everybody stands in a line and then you step forward. I think everybody stepped back, and I was the only one that didn't pay attention or get the memo. So yeah, so it's been about 5 years.
you and Holly. You're just
Yeah.
such good partners. You're just good at it.
Tag team. Well, Holly threatened me one time, so I don't think I can.
She's like, "Don't you dare not step
You
up."
better not.
Yeah. And in addition, and I think particularly interesting for this conversation, you're on the Care Everywhere Governing Council. I think it would be useful. We'll circle back on that to talk a little bit about exactly what that is. You are also on the eHealth Exchange board, another network, and QHIN. And Carequality Implementer. And then in addition, you're getting very involved in FHIR and on the HL7 FAST Da Vinci committee member. And then a fun fact, you are a special correspondent on the Health Tech Talk Show, which is fun. So I love it. So I think we're just going to dive right in here. We are now officially 3 minutes in, so we'll get moving.
And just to point clarity, I'm not on all those concurrently. The HL7, FHIR Scale, and Da Vinci work is stuff I've done in the past, although I still am active with Da Vinci. But the Carequality, Carequality, and eHealth Exchange are current active industry participation stuff, as well as California stuff. But we'll get into that.
Yes. We may have a chance to talk more about California stuff later.
Yep.
So we wanted to just dive right in, and given all of that background, I think I personally am really curious about learning more about the role that you play there at Sutter Health. So I don't think I mentioned that. You are a employee of Sutter Health. Can you define kind of what your role is there, and how that kind of informs the work that you do externally?
Yeah, so I joined Sutter in August of last year, and I'm essentially the HR role as Director of Digital Applications, but my responsibilities are overarching for all of Sutter Health Enterprise Interoperability. So as an Epic shop, I'm responsible for the Epic products, Bridges, Interconnect, Care Everywhere. And then from a platform standpoint, we have a middleware platform and a secure file transfer platform that my team manages, as well as an API gateway. So essentially, from an enterprise integration standpoint, our team and my responsibility is to manage that. I also, interestingly enough, am responsible for the Epic Community Connect program here at Sutter. So we have about 250 independent practices that leverage Sutter's Epic environment to run their independent practices. And I also uniquely manage all the integration points that they want to have with our Epic environment through those processes. So that really informs kind of how we as an enterprise, do app rationalization. So we make sure we don't have 7 different versions of the same product integrating, doing the same thing. So sometimes there's in large organizations, you find that some things are maybe fairly stovepipe. So creating visibility and information that I can share across the organization and connecting people who may not be aware that things are happening. I think if you somebody may have seen the news recently that Sutter's invested a good amount of money in bringing WellSpace Health onto Epic environment. That was done by a different part of the organization and may have been appropriate to be part of our Connect framework, but they've decided to do something different today. But again, just kind of how large organizations work. Not everything works as seamlessly as you want, but we're trying, at least in my area, to create an enterprise frame for those connections. So.
That's very interesting. And now I'm going to go deep here because I know some of the folks on this call are probably really curious. So you mentioned that you have these provider groups that you're providing Epic to. So they're out there, kind of underneath your umbrella, leveraging technology. So let's pretend, so there's been a lot of talk, as many of you know, in my prior office hours over the last 90 days about this new delegation of authority process that Carequality adopted that was to better align with TEFCA, which replaced the old on the behalf of use case under Carequality. And I'm curious, Michael, have you had a chance in your world yet with those other provider groups where maybe one of them decides to buy a new piece of technology? So let's say they're a cancer care provider and they found the best AI tool that's going to help them specifically, manage the care plans for their oncology patients. And all of a sudden they have a delegate of authority use case. Have you had that come up where you've had to kind of be part of those conversations where one of your provider groups that's using Epic needs to have your help potentially in getting a delegate notice approved or understood?
Fortunately or unfortunately, I have not, Marilee.
Okay.
So most of the third-party integrations is they have clinic operations that they're trying to run. They have an application like a recent one. There's an application where a pediatric clinic is sending out questionnaires, very pediatric, high-end pediatric specific, and they want to send some scheduling data. They want to get some of that survey data back from that particular application. So we broker that connection. We haven't had anything where one of those partners is really looking to use a third party and pass a kind of a network query through to Carequality or through TEFCA or any of the networks back through to actually directly pull data back, as I think that example on the delegate process works. So I think that if the third parties were coming through us and doing that, and we were, I don't know how they would execute that query. So they'd have to really connect directly, but it's not something I've dealt with. I think that in the conversations we've had, my responsibility is to protect the legal medical record, ensure the right sign-offs. And is for those of you who've been through the TEFCA onboarding process, of the 250 sites, about 25 of them failed the first pass through that process for onboarding onto TEFCA. So we actually had to bifurcate our TEFCA implementation. We went live with Sutter and about 200 sites, and then we had a number of them that had to kind of go back through that process, that verification process. So we will go through the same process. Any third party, we do a risk and security assessment with our security team here at Sutter prior to even connecting them to V2 integrations, much less any other process. And
Right.
we would anticipate that anything that we ask them to do, that there's sign off. And if we needed to connect them to the network, we just follow standard process and protocol there and add that into the authentication. So, my opinion is that anybody that's connected to the network, if they're not a covered entity, then a covered entity needs to, sign off on access on their behalf, and they're kind of acting on their behalf. And that process through what I do today and what I would do for a delegate would be the same, whether it's required by the network or not. Just from a personal standpoint, I feel like making sure that the provider organization that technology service provider is working on behalf of is aware of that arrangement, acknowledges the risks around allowing them to query, what their responsibilities are, and kind of covering all those bases of concern that I have around that sort of arrangement. So.
Well, and I think that perspective is so helpful because for Zen and for those of us who are enabling a lot of those delegate vendors that are sitting next to the Epics or the Oracles or the Nextions of the world. It is interesting, especially in the size of organization with a big enterprise like you're managing. I think it's very helpful for us to get your perspective. So I really appreciate that.
Yeah, and Marilee, I think just from that point is, part of the conversation that we've had in committee is, who's responsible for that? And I think that what happens is the vendor comes in and wants to get access, and there's a one step away from the provider organization or the organization that they're trying to do the work on behalf of, because they're misinformed or uninformed as a provider organization how it works. And I think that that's where, to me, you've got to put the onus on the customer who's asking for this technology to partner with that vendor and get that authorization prior to coming to the network, and make them responsible for that, as opposed to you as the network or onboarding organization to try to run that back down, or even Carequality all the way back through. That's really difficult to manage. I think that really needs to be the entry point for those participants. So.
Yeah. And I think we're doing a lot of education for our health tech vendor customers to say, here is the conversation you need to be having with those provider clients, and making sure that they're getting engagement with the right stakeholders, on their side, especially when they're not just like a standalone practice and they don't have any other connections. It's just making sure all the stakeholders are in the loop. Let's pivot a little bit to, so this is cool because you obviously Sutter, obviously in your role, you're on the eHealth Exchange board. What networks does Sutter Health participate in right now? I think we're very much right now in a multi-network environment. So really curious what network Sutter Health is participating.
I'd like to identify a network that we don't participate in, Marilee, because we're connected to all of them. And again, that there's some framing there. I jest a little bit, but as you're aware, as a Carequality implementer, CommonWell and eHealth Exchange are connected through Carequality. So you technically have access to all three networks through Carequality. But separately from case reporting and some of the other VA and DoD connections, we've been a long-time participant in eHealth Exchange, and obviously I'm on the board, so I'm not going to suggest that go away soon. And I think that as we look at new use cases coming on TEFCA, then we'll revisit that. But I think for today, we are part of the eHealth Exchange. We are part of Carequality, and by being part of Carequality can access the CommonWell participants. And then in California, we're a signatory to the data exchange framework. Here in California, there's a state-specific framework, or it's more like an agreement that you sign to say you're willing to participate. There's no real technology. Currently, there are something called QHINs in California that don't operate exactly like the QHINs as a kind of onboarding or network on-ramp. They can do some of those functions, but it's not the same setup. And if you have California questions, I participate in some of the technical advisory committees here as well. Feel free to reach out to me there. But so we're participating all of them. And I think that part of what we don't want to do, Marilee, is as we go through this transition, and I think, as a member of a lot of these things, is I think TEFCA can or could be the future if done correctly. And I think when you're looking at different purposes of use today, everybody's really trying to cram their solution stack into a treatment purpose of use, as opposed to having something be really a covered entity with a provider and a patient, and we're going to exchange for treatment, versus some of the other things. And again, some of my friends will disagree with me, but I think that maybe care gap closure that organizations want to do to get information about closing care gaps for patients, that really feels operational to me. Now, whether it is or it isn't from a policy standpoint, I know that it is covered under treatment for a policy standpoint today, but I think that as we move forward, being really clear with those definitions and eliminating some of those muddy waters will help. But for now, we don't want to create an information gap for our providers in getting access to data. So we're going to participate everywhere we think is meaningful. And as the sands shift and there's a clear direction on those other purposes of use, or we find other channels to connect, we'll do that. But for today, we're going to continue participating where we need to make sure that information is needed, where it's needed is available.
So awesome. And I'm curious because I think you're opting into TEFCA happened in 2023. 5. Talk to me a little bit about what was kind of the tipping point for Sutter Health to go, yes, it's time to go ahead. And we know that Epic's been putting some, please, customers, we'd like for you to.
Yeah, it's the, I think the last year and a half have been the year of the pledge. We have a X number of customers. We've signed the pledge to be part of the national health infrastructure, whatever the heck anyway, aligned networks, right? It's the aligned networks participation, right? So part of for us again is, we have a lot of use cases for Sutter Health where we want to connect. And part of my vision is to eliminate some of the clearinghouses and middleware that's in place that eliminates the ability to connect directly with business partners. So for me and for us at Sutter Health, looking not only at what we have today with treatment, kind of treatment is, as people say, as table stakes, but really when you look at the ability to do operational exchange with health insurance and payment, right? So payment and ops are the next kind of things. Again, there are other purposes of use, but I think that for me is looking at how we connect with our partners that provide coverage to our patients or their members. And again, depending on which side of that wall you're on, it's a patient or a member, and really looking at how to build that. And again, I'm an Epic customer. I think Payer Platform is an interesting tool. As everybody's aware, there's legal wranglings around what it is or isn't. But personally, I think that my relationship, or our organizations, I say my because I take ownership of this stuff, but our relationship with Blue Cross, Blue Shield, Aetna, Anthem, United, Humana, name a health plan, should be a direct relationship. And I think if the TEFCA can facilitate those technical connections, ensure that we're exchanging appropriately for that purpose of use, and really clearly define what we're exchanging, because on the provider side, there's a history of distrust. Again, regular contract negotiations. There's a very contentious relationship, right, between insurance companies and providers historically. And so that trust is very low. And to be a data liquid environment where you're exchanging data freely, you have to have high trust. And so if we can provide real clear guardrails around what data is exchanged, why it's exchanged, and make sure that those rules are followed. And I think that the TEFCA framework can help build those things. As you can see, we're kind of poking around at defining treatment. What is treatment? Well, in the first cut, we've missed a few things. So how do we, again, I'm using we, but how does it go? How does the legislation or the TEFCA governance process go back and go, okay, that we missed in our first definition, there's some provider classes that really should be included, or covered entity classes that should be included, because we created some, artificial, barriers for them to participate. Let's fix that. And then what are some things that need to go into ops, and how do we fast track or at least move forward with some operations? Again, very pointed use cases where you can build trust, you can build connections. And then to me, the long term is I get rid of clearinghouses. I have, through my QHIN, a direct connection with that insurance company. And again, no, I'm not sure how to say this, but I would prefer not to have Payer Platform, and I'd like to just connect with my partners. But that's not a viable solution today, and I'd like to eliminate that cost for the insurance companies, and let's redirect the amount of the money that they're paying Epic for this solution to this technology and connecting directly with their customers. But again, that's my personal view, which is why we're moving this direction.
Yeah, well, that is very interesting. And I did want to call out, for those of you who aren't as familiar, there are 3 operational use cases. I said looming in my notes because I have questions. And that is care coordination, case management, and I think particularly care coordination, when we drop it into operations, we're really talking about like population level as opposed to individual care coordination that you're going to do for an individual patient, which is clearly in many cases may fall under treatment. But there's certainly other care coordination type activities, especially those being done by payers. And TEFCA says, by definition, a payer is not going to qualify for any sort of treatment, use cases. They've kind of cleared up any gray zone there. And so we've got care coordination, case management, HEDIS reporting, and quality reporting. And then there's payment, but payment, there really hasn't, I don't even think there's a SOP for yet. So payment to me, it's like we aspire to payment, but they haven't really gotten around to that one yet. But for those three, what I hear you saying, I just want to make sure I'm understanding, is that, hey, great, we got the plumbing, we have the shared certificate, and people should be used. And so what do you think it becoming mandatory, because that all kind of exists today as a published SOP. What is mandatory? I had two questions. How do you think about it in terms of it's a mandatory response? And number two, in keeping in mind that payment is allowed. So I'm curious, to me, I'm having a hard time getting those two concepts reconciled in my head. And I'm curious how you guys are thinking about it.
Yeah, I mean, I think that for us, as we have partners that are plugging into the TEFCA infrastructure, I think that I appreciate actually the narrowness of the use case, because we know exactly what we're doing and why we're doing it. And my concept is, even within TEFCA, there could be some concept of like trust levels, like insurance providers that we're contracted with. We have trust level 0, and we're exchanging fairly freely and openly for the shared patient population. For insurance companies that we're not partners with or contracted with, maybe there's a trust level 1, and there's a different level of exchange across the same networks, but maybe the same. If we look at fire at a resource level, maybe different resources are shared. But I think that as we move those forward, and we look at kind of whether it's payment or the use cases that you talked about, I think the optionality piece is that is saying that we may have current methods, and this is where this gets really cumbersome operationally. We talk about administrative burden. Where the administrative burden gets significant is if I have 2 payers that are participating in this way in this process, and it lands here, and I have 10 others that are doing this thing, then it makes it actually more difficult for my groups to manage how that data comes into our system, what the workflows are, and how to process those electronically as a singular workflow or a singular work group. And I think that's where, when we get into things like payment, I think the big beautiful bill is going to put a hurt on a lot of healthcare organizations. Our organization is kind of has internally talking about the financial impacts of that bill and some of the cuts that we're all going to experience, right? So what does that look like? Is how do we do more with less? How do we automate and do things in a way that allows us to streamline as much as we can? And if I have one workflow over here that does this, and 2 others that do this, and one that does this, it's like I'm going to be unable to manage that, especially around something as important as payment. So I think that's where, when we talk about care coordination, that's the kind of the front end. When you start talking about back end stuff, and you're starting messing with organizations' money, I think the ability to have optional is probably, until we really understand it, probably a good way to go, so that you can find a partner and say, yes, I want to opt in, and this is the benefit to my organization. And that's really been a challenge, even for as long as I've been involved. Is I like to be on the front end. I've done 3 different pilots on DaVinci ePrior Auth from different perspectives, and getting the IT pieces and parts plugged in and making sure it works are all easy. Getting the operational people to plug in and understand the value and understand the automation and really line up and say, this is really cool and it helps me do my job better. That's been a lot harder, and even with auth, because again, I'm going to have 3 payers that are going to send electronic auth this way, and the rest are going to do it the way they do it. Log into the portal, send a fax, whatever it is. Even internally at Sutter, we have a lot of providers that are still leveraging fax to send information back and forth because they don't understand the technology or how it works. So I think I probably have gone around and round on with you, Marilee, there, but I think that's kind of where I sit.
Yeah. So what I'm kind of hearing you say is, it would be awesome if we could leverage again, these specifications and SOPs, and the plumbing that is in place with TEFCA, so that you can have more homogenous solutions where you're not having to manage all of these different one-offs to the extent that it's possible. And I think we all know that, crawl, walk, run, you don't go from 0 to 100. You have to, change happens over time. But it is, I do think that, I think it is really, I'm feeling really good about the fact that you guys Sutter is certainly, and because I do think that people like Sutter will influence others, right? So if you guys embrace some of these emerging operational use cases coming up in the first quarter, that you start to create momentum for those use cases by just saying, yes, we're in. Tiffany, did you have a question?
I think Tiffany's just unmuted. It's
Okay,
okay.
that's cool.
All
Well,
good.
I wanted to make
But Tiffany,
sure
we welcome your question
we
in person or
welcome.
in chat.
This is a good time. If anybody wants to jump in with a question about anything that Michael and I have been talking about, please feel free to jump in. If you're really shy, throw a question in the chat. But we love your participation.
Or we could just go back to talking about where you went to high school. And
Oh,
what
that's
movies
right.
you made about
Yes,
it, right?
that's our fallback plan. For those of you who missed the beginning of the call. So for those three particular operational use cases, those are where fees can actually be charged for those. And I'm kind of reading that, and honestly, I haven't read through the SOPs in detail yet, but I'm curious, in your mind, does that mean, okay, Sutter Health, when they are engaging with a payer to facilitate a HEDIS reporting or a quality reporting or care coordination case management, I'm going to negotiate with that particular payer to come up with the price. How do you see that working?
Yeah, Marilee, I mean, most of the time when I'm building interoperability solutions, we look at the upfront costs and we say, this is the cost to do this thing. And then the long-term benefits over time. Actually, I've created or I've moved into a new reporting relationship, and my new the COO who I report to always talks about the value of the work that we do, right? And so if you look at traditional, I'm going to go a long way around to answer your question, but when you look at traditional HL7V2 interoperability, it's assumed when I do an ADT and I send that ADT to 80 systems, I've eliminated redundant data entry. I've improved data quality. What is the actual value of that thing? If I spend $50,000 to implement this particular integration, over the next 2 years, I've recovered that times 100 by eliminating those redundant data entry processes and improving the quality of that data. And so from that standpoint, when we look at the cost, I would look at it the same way. There's an upfront in the door cost of building that integration, and whether we charge it or whether we figure out how to share it or whatever that looks like, that to me would be the essentially in the door cost for that partnership. And whether I'm paying it or they're paying it or we figure something out along the way, I think at the end of the day is that investment recoups itself over time through the integration and automation. And I think that where you get to the types of exchange where they're essentially charging per transaction, I think that those are the sorts of things that over time people get resentful of. And as much as they improve the process, the increased costs, because if you think about even V2 or even CCD exchange, there are billions of transactions. If you were charging 0.01 cent per transaction, like that weird thing where they stole the 0.01 cent off the payroll and send it to an account in Sweden, right? You'd be a multi-billionaire. And I think that creating profit motives off the back of transactions and automation doesn't make any sense. I think recouping the costs of that upfront build and integration and figuring that out is the best way to do this so that you can increase that adoption and you can deploy it in more and more places. So does that help? That how I would approach it anyway?
Yeah, and the way I'm interpreting that the payment side of it specific to TEFCA,
Yeah.
because the integration really at that point isn't a problem. The integration is essentially done. It's just adding
Right.
an exchange purpose, and following the technical requirements of that SOP. But I think some of the people I've talked to are saying, well, let's assume that in the scenario where the payer is the one getting the data and the health system is the one that has the data, it's the value of the data itself. They're not necessarily, the payer should pay the health system for the data. because it's our data. And that's why I think where we are going to get into some interesting conversations this year, the rest of this year, as we head into the first quarter of 26.
Yeah. It's interesting that you said, because there is a concept of who, back to my value statement, is the value of the data that's received through that exchange and who gets to profit, again, using my finger quotes here, using it, who gets to profit from that exchange, and are they bearing any of the cost of that data creation or the infrastructure to support that exchange, right? And so if someone saves, again, let's pretend that somebody saves $100 because they were able to get clinical data from me to facilitate a care gap closure, and it checked a box for quality measure, and that increased the incentive or the quality payment back to the doc, and that $100 is what was the realized value of that specific transaction for that care gap closure. It's like, at the end of the day, there's none of that comes back to the originating entity of the data provider, right? And so trying to balance out where the value prop is and who's paying for what. So maybe it makes sense for the value getter of a transaction to actually carry the cost for building that. So again, I'm just going to use a round number, not that it costs us much, but let's say it costs $50,000 for me to build this integration, and all the value is on the other side, then maybe it would make sense for them to cover that cost for me. Not that, and this is where you get into that weird space of what's out of pocket. So what do I have to pay for licensing versus what is operational costs, where I've got sunk costs in FTEs that are fully loaded. That's what the per hour cost for them to do this work is, and testing and that sort of thing. So,
Yeah.
I've got lots of theories and formulas for calculating the cost of new integrations, but I think that who pays for them is a whole other question.
So speaking of direct integrations, and I promised several people that I would, and Greg's got his hand up, so Greg, I'm gonna get back to you here in a second. But I want to kind of pivot once we handle questions in this kind of more TEFCA national network space, to how you think about direct integrations and kind of what your process is. But I'll pause here for a minute. Greg, I know you had a question that I think I answered in Slack, but do you have an additional question?
Yeah, I do. I'm just kind of curious. I like what Michael's saying about like who pays for what. I think about that stuff all the time. One thing that is on my mind is a lot of this stuff and solutions that we're building are, happening inside the cloud. And the way that we pay for things we do is the more people use our stuff, the more we pay our vendors who in our tech stack. And one of the things Michael said was, kind of frowning upon charging based off of usage. But for vendors who have solutions that, like, it's kind of, that's something that the more our network gets used, right, the more cost we have.
We have to pay more money to whoever our whether we're doing Amazon or Azure or have our own private cloud enterprise architecture. More data flowing means more cost. So yeah, there has to be some sort of scaling component, especially if you're a middleware provider or filling in gaps for people as a technology provider, which is a little different maybe. Although Michael, you've got costs too.
Yeah.
Right.
Yeah. So, and I think that there's a difference between compute and process and storage versus Epic is a super chatty application. And so if I'm paying 2 cents for every ADT transaction that I generate or exchange, and I send 7 AO8s because in the workflow, I update the address, that's an AO8. I update the phone number, that's an AO8. I update the insurance, that's an AO8. So now I'm paying for the same update, I'm paying for 7 transactions as opposed to 1 transaction. So I think that there's, to your question, Greg, I think that there's some reasonable cost recovery on compute and process and storage that does make sense based on usage. There are vendors that charge per transaction costs. Like I send 1,000 transactions at 2 cents a transaction, that's $200 or whatever it is. Again, I can't do math on the fly. But I think that's where it gets a little more I'll say nebulous on how that cost, what the value of those things are. But I completely agree that, yeah, if I have computer storage or usage costs in that way, like we all have costs depending on how you license your product for, named users versus concurrent users, that sort of thing. So we're all paying that sort of freight. I think that as you look at individual transactions flying through the pipes and you're trying to calculate a cost and then essentially bill for the cost of that transaction, it gets a lot more murky as to like what are you charging for and how much of that is redundantly exchanged as opposed to what the end goal is. If you could actually fix V2 to only send one transaction for the value that you're looking for, like minimum necessary, then maybe we could get there. But that's not how these networks and data exchanges work today, which is why I'm probably overly stating my objections to that sort of cost model, but I understand it for sure.
Yeah, we are very familiar, given the amount of HL7s that we process around here with chatty ADT feeds. So let's talk about the different ways that different pieces of technology integrate with you guys at Sutter. So maybe walk us through how you kind of think through what the options are, and kind of where you see the most action happening, maybe.
Where I see the most action happening. Well, action every day. I can pull up my project portfolio for right now. I got about 120 new projects, but let's just talk turkey. I mean, honestly, if you want to be interoperable with Sutter Health, you need to comply with existing standards. So, we're talking HL7. So if you're a vendor and walks in the door and says, well, we don't do HL7, you're probably going to get knocked down on the list as far as priority or even our willingness to do that exchange. And I have some neuroses here because when somebody says they do HL7 and then they talk about Fire APIs like it's separate from HL7, even though Fire APIs are an HL7 standard, that tells me that the vendor doesn't understand the technology and they're just wanting to talk about cool things like Fire API. So when you look at prioritization, first thing in the door is, do you do HL7 interoperability? Or if you're on the other side, if you're doing X12 or EDI, I mean, we don't do a ton of that at net new anymore, but most of it is V2 HL7. Most of that is because of the workflow drivers, is that the workflow inside the electronic health record is driven to create transactions based on activity. Whereas the API is more of a request respond. I need to be able to know some information to come back and get some information. So we actually have a lot of design patterns where we're sending an ADT so that a Fire-based application can come back in and get the resources that they need. So it's a very stripped down, here's the demographics, here's the information to know that activity occurred, and then they come back and pull whatever Fire resources, whether it's a med list or a problem list or whatever it might be, a document or a lab report. We have a lot of that pattern, but for the most part, 90% of the stuff we do is either a V2 integration or it's a Smart on Fire embedded app where there's a launch point inside of Epic that then creates, again, you push a button in Epic, so you have a workflow driver that launches that app, SSO based, context based, linking out to whatever that third party app is. They do their business, and if there's some write back, they write it back. Or obviously in the V2 pattern, if it's a ADT, ORU, ORM, I think we're all very familiar with those message types. And then most of the time, the CDA stuff happens. Like we have a couple projects. Actually, one of the interesting ones is care gap closure. Is we have a partner with some of our independent practices who's doing a lot of their quality reporting, and that vendor is looking for CDAs at the end of the visit. So we have a pattern where we send them scheduling, we send them some other information, and at the end of the encounter, we send them a CDA so that they can have that. So, and actually we're piloting that now because today the only response through Care Everywhere is for treatment. If you want to do something other than treatment, there is that similar technology and mechanism exists, but they don't call it that. They call it automated CDA. But you can do essentially CCD exchange through automated CDA as opposed to Care Everywhere, but it's essentially the same technology. And so we're actually currently working to pilot that use case for some things like care gap closure and auth and some other ones that we're looking at. Again, trying to build the capability to do these things before somebody knocks on the door and actually says we need to do these things, or the government says you have to do these things, right? So
Yeah, and that's a big one. I know a lot of our regional HIE friends, they have a number of hospitals and health systems that will do that CCDA push workflow that you're talking about, because they need to see, they're in a case where you have a regional or state HIE that's aggregating data for the community, you need to get that full clinical picture for their clinical data repository. So, and I apologize for some of you. I'm going to do a quick technical, going to throw some acronyms out here, but I'm just curious. I have to satisfy my curiosity. When you're doing that push, you mentioned it's the same kind of technology for national network. So I'm assuming when you say that, you're talking about maybe an IHE transaction, perhaps an XDS push, or XDS.B, or I know there's some, you can do it via XDS too. There's a couple.
Yeah, I think it's XSD, but XDS. I always get this. That's why it is.
Yeah.
But essentially it works the same. It's a query response. So somebody requests data for a particular patient, but instead of having treatment, they have operations as the request for that data before it gets pulled back. So
when you're doing pushes at the close of every record, is that also an IHE type message? Because I've seen some people attach those to HL7V2 messages. And
no, it's not V2. It's it's an XML transaction. This is where you're farther in the weeds than I get these days.
Okay.
Really, I used to, in my old job, I used to actually have a log on and I could look at that stuff. And when I got to Sutter, they didn't give me a login. So it's been at least a year since I looked at that XML to know for sure. But
well, and for those of you on the call, the XML document of the CCDA, you can attach that XML document to different kinds of messages for transport. So we've seen people use an HL7V2 for transport with that XML CCDA document attached. But the more common way for those pushes to happen, and what we're seeing from big hospital systems, is using IHE, which is more of that web services, old school legacy stuff. So interesting. Okay, very cool.
We're trying, and realistically, I like everyone else is trying to move to FHIR, but until we have some sort of internal trigger mechanism that allows us to inform that something happens outside of V2, it's really hard to figure that out. I mean, we've done some experimenting with bulk. Bulk doesn't really work very well today with Epic, just because there's a requirement for the patients to be in a registry. There's some limitations on the types of resources and response times, depending on how, what sort of information you're looking for. Very discrete, like, again, problems, meds, allergies, things, encoded data. Response time's pretty good. Anything outside of that, especially when you're looking at a document resource, response time's pretty crappy because of the volume and size and scope. So the architecture currently doesn't do a great job of supporting bulk, and there still is a push. You still have to give the key, even if they're coming and getting the data. There's still a key exchange sort of thing with Epic to enable bulk as it is. You can't just come in and request a bunch of APIs in bulk. Not like concurrent query bulk, like the bulk process. And Josh Mandel, if you follow him on social, he's done a lot of publishing. Part of the pilot program we worked with was with Josh on some of that initially as well.
So when you mentioned about vendors coming to you and kind of maybe not recognizing that when you say the term HL7, that's a pretty broad brush. You've got V2, you've got V3, you've got FHIR, as opposed to being specific and saying, oh, I am talking V2 here. Are there other things that just kind of you feel slow things down, or maybe create some friction when you guys are interacting with vendors that maybe could be helpful for some of our vendor folks on this call?
Yeah, I mean, I think the big one, and I have an example of it today, is I have a request for a vendor that comes in, they give a high level document saying they want this information, and I turn around and say, hey, great, are you, as an Epic customer, are you in Epic's showroom or vendor services or app orchard or whatever the hell they're called these days, as well as, give me your technical specifications. What is it that you do? How do you connect? What messages are you looking for? What's the required fields? What are the non-required fields? There's a ton of vendors that have no technical documentation, and it doesn't need to be super detailed. It just needs to outline how to connect. So do you support HTTPS? Are you a site-to-site? Do you need a VPN? Do you want a secure file transfer like basic stuff like that. I want an ADT. I need these message types. These are the required fields. Like there are so many vendors that are new entrants that don't even have basic technical documentation. Again, when you look at vetting a vendor, spending the time, and they say, well, we'll take whatever you've got. Well, now I'm giving them my spec, and now are we building a custom interface? And we do regular updates. I mean, we go through a process at least twice a year where we're updating Epic, and Epic V2 interfaces change. They just do. Sometimes known, sometimes unknown. But when something changes, you have to go to every endpoint and go through an extensive testing process. And if you've got a vendor who doesn't understand what V2 is or how it works, and they're just wanting to consume data to get past the sales line, and they're not technically sophisticated enough to understand what they've built and how that processes, that for sure is a red flag for me. Is we're going to have trouble with this vendor, and we may want to look at somebody else if we can. So walking in the door, being conversant with the standards, understanding what you want, and really talking through the workflow. This is how the product works. These are the message types. This is why we need this data. Because if even in the Epic world, is a lot of vendors will come in the door and they'll list every single resource possible, because at some future point they might want that data, as opposed to, I need this data for what we're doing today, and I may need this data tomorrow. And so then it becomes very murky as to, why do you need all these resources to do med refill,
Right.
patient outpatient med rec, right? It's like, okay, this doesn't make sense. So that sort of thing also is something that raises a red flag for me and says, okay, there's something else going on, because they're looking for 100 resources, and for what they're talking about, they only need these 4. That doesn't make any sense either. So
Can I ask a question? Sorry, I don't know how to raise the hand in Zoom.
Oh, you're good.
Do it, Paul. You're
Come
good.
on in.
This is a great conversation right here. And can you talk a little bit about the cart horse problem? And what I mean by that is, I've been in the Epic App Store. I've done integrations for best of breed vendors that do not have their first client yet. And so often they'll go present their solution to somebody like Sutter, and Sutter will say, oh, are you live yet? And they say, we're not live yet. Or Sutter will, not you, Sutter, but, rhetorically speaking here.
Yeah, you're good. You can use me. I'm here.
Yeah. Or, hey, I'd like to see what that looks like in Epic. And the problem with the App Orchard is you cannot get a actual Epic instance, right? You have something that roughly simulates the behavior. And in fact, some fire calls, if it is a fire, an integration of type fire, it doesn't persist the data. In other words, if you post a document into the test instance of Epic's, App Orchard.
Yeah, the sandbox,
Sorry, the sandbox, it goes away in a split second. So let me get to the question is, what do you suggest for that? And by the way, I'm an integration provider. I'm not a best of breed vendor, but I get called to do this. And they're in the world to go, I don't know how to get to that first client that will let me actually send data to a real Epic instance, that sort of thing.
Yeah. So here's where the IT and operational partnership works, is that obviously if you've got 6 customers that are interested in this, you have a use case that's going to solve a problem. Because what I tell vendors, and I do a lot of advising, is what I tell vendors is, come with a problem first approach, not a technology first approach. And I think we all experienced this through blockchain years ago, is blockchain could do everything, including toast your bread, right? And now we're in the same world where AI is going to do everything. AI is not going to do everything. It's going to be a really helpful tool, useful tools. But for you as a vendor, Paul, or as a partner, is make sure you have an operational owner and you're solving a problem that they want to have solved. And then they can partner with IT. I've done a ton of this with lots of different vendors. It's very easy for us. Without even you being an App Orchard, we can establish a client ID. We can give you direct access to Epic's Fire APIs through that client ID, through OAuth, with just an enterprise log on into your test environment with the right resource security, right? So if you have a partner who wants to build this integration, they get to their IT resource. And in most organizations, you're looking for a care everywhere person, because they're the ones that tend to build this stuff, especially smart on fire type integrations, or deal with the APIs, or they at least know who deals with that stuff inside of most Epic organizations. From there, you can build that in a test environment without having to go to pay the Epic tax to get into App Orchard or vendor services. You can build that direct integration. You can work with them. Epic has kind of lowered the threshold on screenshots. I think there have been some things about, not sharing screens or being
For
able to share.
sure.
I think some of that historic prohibition has been lowered for whatever reason. And again, I don't know all the back end stuff, but anyway, that would be my recommendation is make sure you have an operational partner, have them engage with their IT folks. And then kind of as I talked about earlier, come in with a really clear understanding of what it is you need and why. If you say, I need to access these 7 FHIR resources, and if it's read, it's even easier. Write back is a little more, I'll say I have some stuff that they want to write back and Epic has enabled those and then become custom APIs and it gets really messy. And I actually just tell vendors, just write back an ORU. It's going to be easier and quicker. Not that you want to do that, but that's just the current state.
That's what Zen says too.
It's funny, right? Because a few times I've said, you're going to need to do this with HL7V2 because there's no real subscription in FHIR for Epic. So you're going to need to get the notifications. So I again, I'm long-winded. I apologize, Paul, but I think that the operational partner is key. Finding the right IT resource, connecting to an Epic test environment is not a huge lift. And again, if you would like some, feel free to reach out to me directly, and I don't know that I can offer Sutter as a partner, but I can at least talk you through this, or even just talk to the customer that your partner is dealing with and kind of help them understand what they need. Because some of the stuff that I've done is because I ask a lot of questions and I'm curious. And I also like to understand stuff before I actually have to do it. And so some of this back-end stuff of doing it outside of the Epic App Orchard and going direct through Interconnect and using OAuth through a test environment and specific resources is all stuff that's available to every Epic customer. It's just if you're dealing with the wrong people or you don't have the right resource or somebody who's done it before, they don't understand and they'll just tell you, well, you have to be an App Orchard or we're not going to talk to you. And that's not really the case, or at least helps fast track you to App Orchard if you want to do that. So hopefully that's helpful. Yeah, very helpful. Just one last question. Who do you want to hear from internally at Sutter to sort of make that move forward? In other words, I'm an integration person. I'm not a vendor. Go ahead.
Usually my particular opinion is we in IT don't want to own technology solutions. We want to support the technology and help the application or the business process owner implement them. And we want to be engaged early in that process. So again, what I would tell you is if you have a pharmacy solution or a referral solution or a billing solution, who is the operational owner of that process inside the organization you're working with? And then have them be the ones to reach out to the IT folks to say, we need some support in this area. And again, different organizations are have different places, but if you can find the internal care everywhere person at whatever organization you're working with, 9 times out of 10, they can connect you to the right person inside, especially for Smart on FHIR app development. So
terrific. Thank you so much.
Yep. Patrick has his hand up.
Yeah, Patrick, go for it.
And is on video. Although I like
the
black, I like the black lab picture. Not that Patrick, you're better than the black lab, but
my black lab's asleep somewhere, so it'd be alive.
Nobody wants to see my face. So.
Michael, very good conversation because Patrick, me, and I'm the director of product at iHide. So what you guys just talked about, the showroom, Epic showroom stuff, I'm actually trying to determine how on earth to get one of our applications, our FHIR-based applications, available for our Epic customers. And wondering if I can bypass showroom, but it sounds like I can if I work directly with.
You can.
Yeah. Awesome, because I don't want to pay the Epic tax, as you so well put. And the other piece is I'd rather work direct. It sounds like there is a way forward to work directly with our Epic customers, our customers who utilize Epic, in order to accomplish that. So I just want to make sure that I'm thinking along the same lines of you just talking about, and it wouldn't be. Our customers would be querying us for data or using our application to pull data from our data repository as opposed to scrapping data the other way. And so I want to make sure we're on the same page as far as that use case is concerned.
So is that data is that a write back or is that a view?
It's a view only. So it's a view only application. They send us the patient information. We provide the data back.
Yeah. And so kind of an SSO connection. Yeah. You should be able. So basically, if they're reading your application and you're just looking for them to view, Epic shouldn't be involved in that equation at all. I mean, or I wouldn't anticipate, unless they're feeding you data first that you're consuming, doing something with, and then giving them some aggregated response or intelligence back with.
Yeah, the goal is it's a user facing, has a UI component, right? The
Yeah.
goal is to get that UI component viewable in Epic without them leaving.
Yeah,
They should start.
So you're looking for you're looking for context-based SSO
Yes.
through a
Yeah.
Smart on Fire app. Yeah,
Bingo.
that's all pretty. That's all pretty. Yeah, that's all pretty straightforward. And again, you don't have to be in showroom to deploy that type of solution.
Fantastic. Thank you. I appreciate you confirming
And
that.
feel
yes,
free, yeah, if it would be helpful, again, I do a lot of this on the side. It would be helpful for me to help your customer navigate that with their Epic TS people, I'm happy to try to help them with that process as well. So
awesome. Well, your name is now on my short list. I appreciate it, Michael. And yeah, iHigh's Indiana Health Information Exchange. Thank you, Marilee. I forgot to actually, I'm so used to saying it and not
Everyone should
explaining
know
what
who
the acronym is.
is.
Yeah. Okay. Thank you. That's
Yeah.
it. Appreciate it. Thank you for the
yeah,
comment.
no
guys.
problem. Yeah. Marilee, we got 5 minutes left, and I've talked way too much. Do we have other questions out in the world?
No, you talked exactly the amount that I wanted you to speak to. You mentioned a couple of things that just surprised me, and I want to call that out. I mean, one of them that I'm super excited about, when you talked about secure connectivity for things like V2, you didn't just say, well, I don't think you just said VPN, because our frustration is, and I think iHigh would agree with this and some other people, if I never have to deal with another VPN again, I'll be happy. And so HTTPS, JWT and other more modern based ways of securing data would be nice. And so I just wanted to circle back and make sure I understood that you would do a V2 with an HTTPS type connection.
Not only would I do one, I've done one. The piece is that it's because it's easier, I just use my middleware for it. So that almost everything coming out of Epic comes out of our middleware. So I haven't taken the time to figure out whether I can support it directly out of Interconnect. Maybe I can. I just am too lazy, or I've got other priorities. My middleware does it just fine. So and since we pass all of our ADT messages through the middleware, again, Epic's licenses are by what they call Bridges AIP. Those AIPs come in bundles, or at least for us, they come in bundles, and there's a certain number that we can customize. Of that bundle, we have an inpatient feed, an outpatient feed, and then some custom stuff. In California, there's something called AB 352, which requires us to eliminate abortion services data from anything that's leaving the organization and going outside of the state. Some of our external partners, we don't know whether they're out of state or their home office may, like LabCorp, I think is listed in, or Quest or SunQuest, or somebody's listed in Arizona. So for some of those integrations, we have to strip some of that data. So we've built a new AIP for that particular piece anyway. But so enable us to feed all of our downstream ancillaries. We run that data through the engine. Most of the interfaces go through the engine for formatting and security and support, normalization, that sort of stuff. So
that may be why you hear different things from different facilities, and that, if they have a tool that they know, oh yeah, we know how to do that because we got the tool. And if they don't have the tools, or if you just happen to get the network person that's like, well, I just do VPN. So that's my answer.
Yeah, that's the other thing is, for me, is that VPN management and administration is almost sometimes the longer pole in the tent than building the V2 integration. Like, I can spin up an ADT. Actually, we had a project where we were 2 weeks from go live, and somebody goes, well, we're not going to go live without the scheduling interface. I'm like, well, how did that come up just now? You don't have it now, but they're converting to a new system, and they're like, well, we won't go live without it. And we were able to spin up a new instance and give them, you get what you get kind of interface, but it's not super difficult. I mean, from a quality standpoint, you want to go through all the environments, you want to go through all the testing, but SCED data is low risk. So there's not, patient's not going to have an adverse impact as far as if you send the wrong scheduling field, it probably just won't file. So, but anyway, so the V2 stuff, but sometimes those site to sites take months because you got to get the right security people, you got to get the right protocols, you got to get on the right ports. It's like,
yeah. And thank you for validating, because it's what everyone says to us. Well, how long is it going to take you to stand up a V2 interface? And we do a modern JSON with our health tech vendor. So the hospital, we can talk HL7 V2 legacy with the hospital provider group, the EMR, and we can let our customer talk modern JSON, and then we sit in the middle. But it's always like, how long is it going to take? Well, what you just said is exactly how long it's going to take. If the facility requires a point-to-point via VPN, that's what you run into. It's not an issue of the interface itself, almost, in
Yeah.
almost all cases, it is the secure connectivity when a VPN is involved.
Yeah, for sure. Well, I mean, I think that, I've got lots of numbers around new implementations. I'm always looking for people who have knowledge around, different methodologies and really operational, like how many people does it take to support 100 interfaces or 1,000 interfaces or ADT interfaces and ORU interfaces? Like, what's the operational ongoing cost from a staffing standpoint? I know organizations do it with 3 people, and I know that organizations do it with 100 people, and the numbers can be not that far off. And I'm trying to understand and justify kind of just even operational staffing levels. So
Yeah, true. Well, we are at the top of the hour, and we are out of time. I wish we could have gotten more questions, but you know what? We can have you back.
Oh no, you had a repeat?
I mean,
is this a cliffhanger, Marilee? Are we talking about the cliffhanger?
Agree, I can have you back. So
if you want to know how to get free stuff from Epic, just come back to our next episode.
That's going to be our hook line next time.
Exactly.
Listen, Michael, thank you so much.
You're welcome.
I know that a lot of what you said was very helpful. We just heard from our friends at Indiana HIE how thrilled they are to have gotten your wisdom. And so thanks everyone for attending. Thank you, Michael. I look forward to seeing you in a couple months in Nashville at the National Network meetings. And thanks everyone for joining us. Have a great rest of your day.
Thanks, Marilee. You have a great day. Thanks for having me.
Bye.
Bye.